Why we are talking about it today, because it's a workshop on vertigo, and until we cover all the aspects of vertigo, we are not diagnosing and leaving away many important aspects. So today we are going to talk about Meniere's disease and superior semicircular canal dehiscence, an entity which comes to ENT people. Patients come from all around. They visit neurologists, they visit ENT surgeons, but now, with lot of research in the field of vertigo, things have become clearer. Earlier, vertigo was sort of a vague field. Now, with so many people working on vertigo, things have become clearer, and this field is rapidly developing into something very, very specialized. And I believe that as an ENT surgeon or as a person who runs the specialty of ENT, this is one field which has to be there in your clinic as a separate branch. So what are we going to learn today from this talk? So what is Meniere's? How to diagnose and differentiate Meniere's from other diseases? To discuss the clinical practice guidelines. This is a practice guideline which is given by the American Academy. And this is a guideline which will tell you the proper protocol-based management of Meniere's. And finally, we'll discuss the stepladder pattern of Meniere's disease. Then we will shift our focus to superior semicircular canal dehiscence, which is again a sort of a unique presentation, how to diagnose and finally how to manage. So we all know about the story of Vincent van Gogh, how he cut his ears, what happened to him, he had tinnitus. But essentially he was not insane, he was having Meniere's. Way back in 1861, Prosper Meniere was the one who told about this whole triad of symptoms. And then in 1871, Knappen theorizes dilation of membranous labyrinth. 38, Hall, Pike and Portman tells you that it's about endolymphatic hydrops. So what happens, what creates this symptom is because of the endolymphatic system pressure increase or hydrops. And in 1995, American Academy revised its guidelines and gave what is today called as definite Meniere's and probable Meniere's. Burden is very heavy. Why we talk about that? Because there's a lot of physical impairment, quality of life issues. And can you believe that chronic Meniere's disease is as bad or might be worse treated? It is being treated as sort of as bad as end-stage renal disease or laryngeal cancer. Acute attacks can be as bad as Alzheimer's or as bad as even AIDS. So the burden is very heavy. So how do you diagnose Meniere's? So let's do this as a learning process. Diagnosing Meniere's involves a strict guideline by the Academy which differentiate between definite and probable. What is definite? Definite is 2 or more spontaneous attacks of vertigo, each lasting 20 minutes to 12 hours. Now, when we talk about vertigo symptoms, it's important to realize that most of the diagnosis of vertigo happens with a good history taking and a good physical examination. You do not need very high-fi tests. We have a habit of over-investigating patients. You investigate them when there are red flag signs. So what Dr. Gunjan told us and what my next speaker will talk about today is going to solve a lot of issues as to how to diagnose and investigate. If your vertigo is from minutes to hours, then you are dealing with something of Meniere's or at times some other symptoms which I'll be talking about later. Along with that, you will have low to mid-frequency hearing loss. We are talking very specifically low to mid-frequency hearing loss. This is important in audiometry. And then you will have fluctuating oral symptom. So you have all these three together, you are dealing with a case of definitive Meniere's disease. Probable Meniere's, at least 2 episodes of vertigo with fluctuating oral symptoms and other causes are excluded. So that forms the main diagnosis of Meniere's. People have staged it. Why do they have they staged it? Because we treat Meniere's in a stepladder pattern. And when you decide to switch on symptom severity, and one of the worst symptoms to happen is the hearing loss. And the hearing loss, once from mild moderate, severe. That's how the Meniere's also progresses stage-wise. Various types of Meniere's is being described. It could be vestibular, where vestibular symptoms are more prominent. It could be cochlear, where your hearing loss problems are more prominent. You can have variants. We all know about the Tumarkin's crisis. Patient walking, talking, they suddenly fall down without loss of consciousness. They might not even talk about vertigo, and patient fall down. So these sudden falls are again a difficult thing to understand, usually a part of Meniere's disease called Tumarkin's crisis. Larmoy's has a bit different way to present, but patients do have resolution in hearing loss and tinnitus after vertigo. As I was talking about, Portman and Hallpike told that it's all about pressure increase inside the inner ear. So what happens if you look at the diagram very carefully, if you can look at my mouse, no, mouse is not there. So, pointer, right? Yeah. So if you can look here, this is what? This is the inner ear, and this is the area where you have the perilymph, you have the endolymph. This membrane is the Risner's membrane, and it is bulged up. So there is pressure inside your inner ear duct. I'm talking in very, very base language here, not a proper ENT language. So we are talking about a membrane, which is the inner ear area. And if you look the difference between these two pictures, if you have the difference between these two pictures, this is highly, highly bulged up. So the inner ear, the membranous labyrinth is full of pressure. And whenever this pressure happens, what actually happens? So you can, why does this pressure happen? So it can happen because of obstruction. Endolymph is not being drained out, so endolymph is increasing. It is defectively absorbed, so it is increasing. You can have immunologic insult. That's where allergy component comes in Meniere's. So what happens? So if you go back and look at this picture, what happens? Pressure increases, 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 and then you have ruptures. And what will happen in rupture? You will simply have mixture of both the fluids. You'll have a potassium-rich fluid in the endolymph mixing with a sodium-rich fluid in perilymph. What will happen? Body does not want that mixing. So once it does not want that mixing, you will have all the symptoms. Slowly, as patient progresses, these ruptures become permanent. And once they become permanent, you will have this permanent hearing loss, a decompensated body with all kind of symptoms. So that's what happens in Meniere's disease. So once you have diagnosed Meniere's, you know what is Meniere's about. When you are sitting in a clinic, there are conditions which mimic Meniere's disease, and this is where your proper history taking comes into being. So what mimics Meniere's? I will not go in all details. Dr. Vivek will be covering the peripheral and central vertigo. I just want to mention one entity which you need to understand to differentiate Meniere's, and that is vestibular migraine. We will talk about it in just the next slide. Various other entities, as I told, can have symptoms of Meniere's, but not the all triad. You will not have all the three triad in most of them. Central lesions, again, will have separate red flag signs. You will have, along with vertigo, you will have other symptoms which will differentiate the central lesions from Meniere's. Meniere's will typically have a hearing loss, oral symptoms. Most of these patients won't have that in combination. So why I'm talking about vestibular migraine, as I told you, the American Academy tells one disease which needs to be categorically differentiated from Meniere's is vestibular migraine. And how do you differentiate that? As I have already been talking about, Meniere's hearing loss is documented very commonly. Vestibular migraine may or may not, usually does not. Oral fullness is there in Meniere's. Vestibular migraine may not have oral fullness. Headache is common in both of them. Duration. So why people want to differentiate vestibular migraine and Meniere's? Because the duration in both the diseases ranges from minutes to hours. But then when you look about vestibular migraine, usually females, usually patient will have aura. They might not have aura. They might not have headaches, but they can have subtle symptoms. What kind of subtle symptoms? Patient can have photophobia. Patient can have visual aura. Patient having motion sickness. Patients who are prone to have motion sickness are usually patients who are prone to have vestibular migraine. So that's where you want to differentiate between Meniere's and vestibular migraine. How do you investigate Meniere's? As I told you, do not over investigate, but what is the strong recommendation? So when the academy tells you about the clinical practice guidelines, the key statements, activities are recommendation, strong recommendation, recommendation, options, and no recommendation. So first and foremost, one thing which you cannot miss in Meniere's is audiometric findings, and that is a strong recommendation. What are the findings? What are the tests which you will go? At least first 3. Pure tone audiogram will show you low mid-frequency hearing loss. Speech audiometry should be done along with that, which will give you modest decrease in word recognition score. Impedance audiometry may have acoustic reflex impairment. Then you have some specialized tests. You can go for BERA. Electrocochleography was something which is theoretically taught to ENT surgeons, that patient will have a high summiting potential versus action potential ratio, which is more than 0.5. These are tests which you might do at times, but routinely you don't do. So the academy tells you this is not required. But theoretically, this is what is there. So electrocochleography in one sense is the first wave of BERA, that too in detail. So it will give you a delayed BERA first, increased 5 latency, because your first wave is delayed. Then you have ENG, VNG, where you can have peripheral lesion findings in Meniere's. And finally, radiology. We will give just one slide to radiology, why it is important, because we as surgeons and clinicians tend to, as I said, over-investigate. So academy tells you should not routinely order vestibular function testing or electrocochleography in all the patients. ECOG recommended against. Most of the cross-sectional studies have proven that doesn't add to your management value. Utility of imaging, again, when do you image the patient? Do you image? How many of you image patients of Meniere's disease? Does anybody image Meniere's disease? So usually we also do not image Meniere's disease because we have a typical symptom patient coming to us and we follow them up until unless they have sudden losses, sudden surprises in their symptom, you image them. You go for MRI because it has been proven for asymmetric hearing losses, sudden hearing losses, there is 2.7 to 10.2% prevalence of CP angle tumor, and that's what you want to rule out. So once you have diagnosed, you have differentiated, you have investigated, how do you manage? And that's where, again, these strong recommendations versus non-recommendation versus options come by the academy. So what does the academy tell you in clinical practice guideline? First and foremost, educate the patient, talk to them. Most of the Meniere patients want them to be heard. They are so troubled, they are so nervous, they are scared. Because it is definitely, you imagine having vertigo persistent for so many hours. You can't even function. It is really debilitating. You give them a limited course of vestibular suppressant, that too for acute attacks. You can go for beta-histamine. Now multiple studies have proven that. Then you upscale. So we will talk about that as we go again. So again, just to summarize, you do not prescribe them positive pressure therapy. You do not go for vestibular rehab for acute attack. You do not order vestibular function test or electrocochleographies. That's the summary of main recommendations. So when you are prescribing patients, tell them about the low sodium diet. You tell them to limit their alcohol consumption, limit caffeine intake, give them adequate water. I was always confused whether we should limit water or give enough water. But then there is a big study of Japan. They had 2 groups and they realized that patients who received more water did well. Medication that may help reduce symptoms. I'm not going to tell you the dosings, I'm just going to mention what helps. Diuretics definitely help. So in my practice, we routinely start with hydrochlorothiazide. At times I even give diazide, which is hydrochlorothiazide with trimetrin, and give it for a period, at least to start with 3 weeks. And then you follow up. All these patients are told to get a Meniere's diary. And then I downscale to hydrochlorothiazide 25 milligram BD. But that is something people are comfortable with. Loop diuretics, people are comfortable with Diamox or carbonic anhydrase inhibitors. But I feel one of the very good tolerated drugs are the thiazides. For acute vertigo, you can use vestibular suppressant of your choice. Patient of your choice, and patient's tolerance. That's also is important. Long term, we also give Dehiscence, and we have not upscaled our dose. We still maintain around 48 for a day, and patients usually in our clinic are stabilized with that. Antihistamine may be given for proven allergies. We routinely don't use them. You tell them to come with a vertigo diary. If they are good with diet modification and the drugs, you maintain that. Now the patient comes back to you with, again, severity increasing. You offer them intratympanic drugs. If your hearing is okay, go for intratympanic steroid. Dexamethasone and methylpred, both are used. Methylpred sometimes stinges in the ear because the preservative is like that. So we also routinely use dexamethasone. But one of the best drugs for chemical labyrinthectomy is intratympanic Genta. Today, most of the Meniere's patients do not go for surgical management because of this wonder drug called intratympanic gentamicin. You can range from 10 to 80 milligram. In studies injecting 40 milligram per ml, vertigo improvement was noted in 91% and hearing loss in 91% at a highly variable level. So Genta we offer if you have moderate to severe losses, patient has lot of vertigo, quality of life is diminished, you offer them gentamicin. Multiple studies, but one of the studies which we use here regularly is weekly, which has the lowest rate of hearing loss, 13.1%. So here, gentamicin, can be used on weekly basis. When do you offer surgery? When this also doesn't work, then you can go for endolymphatic sac decompression, which is a hearing preservation surgery. But again, the rate of doing that has come down. When I was doing my SRship, in every week OT, I think we were decompressing one endolymphatic. It was a referral center. We shifted to intratympanic Genta and endolymphatic decompression decreased. We have also done vestibular nerve section in patients in which we had done intratympanic Genta, we had done endolymphatic sac decompression. This patient came back to us. We had to do vestibular nerve section and patient was okay. So it depends how it goes ahead. Non-invasive, you offer them vestibular rehab for chronic. You offer them implants for complete hearing losses. You might have patients with bilateral Meniere's also. And sometimes unilateral Meniere's also, very active people, office-going people, and very troubled by their hearing loss. Why not give them the best option? So, just to end Meniere's talk, this is the step ladder pattern described by the American Academy. Patient comes to you, take a good history and physical exam, 2 or more episodes, as I said, you diagnose a Meniere's patient. If migraine is present, they go out of the guideline only if there is migraine. If there is suspicion, they come back to this, and then you offer them acute vestibular suppression for acute attack, obtain an audiogram, asymmetric hearing loss, go for an MRI if you want. Do not order extra test, should not offer minutes device or positive pressure therapy. Educate the patient, give them lifestyle modification advices, offer them diuretics and Dehiscence. Symptoms control good, no, go for steroid. If no, go for Genta. Again, if no, then go for your ablative procedures, and finally you can rehabilitate them using implants also. So that's what the guideline tells you about Meniere's disease. I'll take 5 minutes to finish semicircular canal dehiscence. It is a unique problem, not very common, but again, when you are at a tertiary care center, you will get such patients who have run all around and finally come to you with a very, very unique symptom. So Maniere in 1998, it's a pretty recent phenomenon people have diagnosed. Absence of bony overlying the superior semicircular canal, resulting in a third window effect. What do you understand by third window? You have the stapes and round window as the 2 windows of the inner ear into the middle ear. You have the third window created by this special dehiscence in the superior semicircular. So you can have pressure-induced vestibular symptom. So your stapes goes inside. What does dehiscence do? Dehiscence allows the flow of a wave of fluid from the vestibule through the dehiscence, and in turn results excitation of cupula and you have vertigo. You have bone conducted hyperacusis. Patients will have such nice bone hearing. If anything, on the mastoid, they listen very well. In pure tone audiogram, you will see the bone conduction threshold is above 0. They can have sub-zero thresholds. So vibration of skull introduces oscillating compressions. These compressions set the fluid into motion, and presence of semicircular canal dehiscence is hypothesized to allow larger than normal fluid motions, which leads to increased cochlear responses. So hearing is far, far better for bone conduction. And finally, you have reduced air conduction. मतलब normal सुनते हैं हम लोग. That air conduction is dampened because there is escape of the wave through that dehiscence. It is rare, not very common, 0.4 to 0.5. Etiology can range from congenital to trauma to developmental. So patient will have chronic disequilibrium. Patient will have oscillopsia. What is oscillopsia? Perception of motion often in a vertical and torsional plane. Patient will have a very unique symptom called tulios. Loud sound, patient goes berserk. They just cannot tolerate loud sound at all. Patient will give you very unique, मुझे अपनी आवाज़ सुनाई देती है, मुझे अपनी आँख की आवाज़ सुनाई देती है, I can hear my own footsteps. So they are so hyper conscious about that sound inside them. They are very, very troubled. And obviously vertigo with chronic disequilibrium is always there. So you will have increased sensitivity for bone conducted sounds. You will have abnormal tuning fork test. Ability to hearing tuning fork even when placed in distal part of bony skeleton. Usually you hear it at the mastoid, but these patients, as I told you, will have increased bone conductions. So you can diagnose them using audiometry, oculography, VEMP, laser Doppler vibrometry. These are specialized tests, and finally CT scan. As I told you, in pure tone audiogram, you will have a sub-threshold method. You will have a threshold which is better than 0. 0 is ideally not zero sound, but that is talk for later. VEMP gives you a decreased threshold, and laser vibrometry gives you a high velocity magnitude. So I'm not going to go in details of that, just telling you that how you can diagnose superior semicircular canal dehiscence. CT scan is something important. You go for the Poschel's view, which is also called the multiplanar oblique. You can see here the bone is not there on the superior semicircular. Very typically you can see that dehiscence, and on 0.5 coronal again the bone is not there. So all those symptoms are happening because the bone is not covering the superior semicircular canal. So how do you manage? So ultimately this is a surgical management. It doesn't get cured by medicine. So you can plug it. Dehiscence is completely closed off with bone wax, bone cement fascia. You can resurface it. Defect is covered with material like bone or cartilage, but the canal is not plugged. You can cap it, just simple capping. Sometimes people even have tested doing round window reinforcement because you want to close one window, isn't it? So technique involves placing some connective tissue around the round window niche to limit its movement and improve symptoms. So you can do plugging, you can do resurfacing. So multiple studies have done which is effective, which is not effective. But essentially superior semicircular canal dehiscence can be very categorically mended by surgical approach, and that's what it leads to. So finally, Meniere's and superior semicircular